On the Go podcast.
From the lab to the future patient, Dr. Sylvia Nürnberger, leader of the Cartilage Regeneration Group at the Medical University of Vienna and member of the expert team of the On Foundation, tells us about breakthroughs in cartilage healing in a coffee break together with Dr. Jari Dahmen, Amsterdam University Medical Center's University of Amsterdam. My name is Taka Oshima, and this is On the Go, the podcast all around orthoregeneration.
So I'm very happy to be joined by Sylvia Nürnberger from Austria, and we are continuing this year of the On the Go podcast with this special guest. And last time we had a clinician with us, and now we move back to the lab, and then moving back from the lab to the future patient, because we'll be talking about the breakthroughs in cartilage repair and regeneration. And we're very happy to have you on the show. And we always start with a kind of a personal question to get going, because this is the On the Go podcast, and usually people are on the go, maybe with their coffee. But how do you drink your coffee?
Yeah, thanks first of all for having me here in this podcast. It's a real honor. My coffee. I drink a lot of coffee, and I start in the morning after I took my dogs for a walk. And it's frozen milk coffee, so I like it with milk foam. And then I continue at work without milk due to practical reasons. And when I get home, when it's not too late, then there is another frozen milk coffee.
All right. And are you usually joined also by colleagues just for a coffee break to talk about some research or some cartilage, or how does that work at your work?
Yeah, most of the time it's I'm alone in front of my laptop with my coffee, but I also like, of course, to drink coffee with my colleagues when there is the occasion. Yes, and then we discuss about science and about our results and everything. Of course, yeah, this is what we're doing.
And for your for the place you work at a hospital or also in the lab? How is that organized for your job?
Yeah, my lab is in the hospital, so it's the Medical University of Vienna. So it's one of the largest hospitals in Europe, and we have research units also here. And my lab is in this research area. And this year in autumn, we're moving to another building. So we will get our own research building. Quite exciting, yeah.
So you'll move outside of the hospital, or is it going to be a research building within like the hospital?
Yeah, it's a separate building, but we are still closely connected with the hospital because it's right beside. Yeah.
Yeah. And are you also sometimes joined by clinical colleagues in the lab and vice versa? So you go into the clinics?
Exactly. I mean, I can join the surgeries if I want, which is also very helpful to understand what the clinical needs are. Yeah. And some of my PhD students are clinicians. So yeah, it's a real good crosstalk between clinicians and researchers. And of course, I have some clinicians which are a bit my consultants when I have question what's appropriate, what's needed, and this is also then very helpful and important that what we are developing is then really translatable to clinics.
All right. And before we dive in a bit into the some content-based questions, could you maybe also tell me a bit about, but also the listeners about your current role or position at the university and what your current activities are?
I'm a group leader. My research group is Cartilage Regeneration Group. Yeah. And I'm doing the research with the students. I'm teaching in the PhD programs. All what's necessary, grant writing, publishing, traveling to conferences, and so on. But mainly leading the experiments and the studies and developing new ideas. That's my job.
And as part of that, you also have some I would maybe call it side jobs, but also some other positions in the field. And one of them being that you're a expert team member of the On Foundation. And in that sense, I would like to talk with you about some of your research, because I could mainly find on your ResearchGate and PubMed and also on the university website that you're doing research on scaffold-based and scaffold-free approaches for cartilage tissue engineering. Could you tell us a little bit about the current ongoing projects that you're working on, and maybe also where you're heading to?
Yes, exactly. So we have one very large project on scaffolds or biomaterials. It's decellurized cartilage based. So this is a more or less novel concept, because we use cartilage itself as a biomaterial. And I call it biomaterial and not scaffold, because scaffold is something which provides a structure where then the cells are distributed, like you have it, it's exactly the same word as you have in front of the buildings when they're renovated. And this is temporary and very porous and very soft, at least in the case of the clinical scaffolds that are nowadays available. And we were analyzing biomaterial scaffolds implants for a very, very long time here. So clinically used materials and residuals of transplants. And we thought we need something which is more load-bearing, which has really the appropriate composition, which has also the right structure, because structure architecture is super important for cartilage. And you have to tell the cells, you have to guide them. And the current biomaterials, current scaffolds that are used in clinics, they are not really guiding, because they have random structures. And so this is then also not so surprising that the tissue that develops has not the appropriate structure. So everybody knows the Benninghofer cards and this fine structure of articular cartilage. And this is super important. And so we thought we need something which fulfilled all this task. It must be load-bearing. It has to have the appropriate structure. It has to have the appropriate composition. And in the best case, it should also serve as a filler, because when you consider the tiny cells on these biomaterials with these large spaces in between, then they have to produce really a lot of matrix. And this is a very high burden on the cells. And so we came up with this approach. We said, okay, then let's take cartilage itself and recellularize it with the patient's cells. So as an allogenic product, to remove the cells and reseed it. Removing of the cells was not that difficult. But then the art, I would say, was to reseed it. And there we have two approaches. One is that we use laser to perforate it. And this is also nice, because then it's very flexible, and which is good for application, and also to adapt it to the curved surface of the joint. And the second approach is that we use auricular cartilage, so ear cartilage, because it's elastic cartilage and there are elastic fibers inside. And when we remove the elastic fibers, then we should have channels, and the cells could use these channels to grow in. And they really did. This also worked out. And now at the moment, we're working on combinations of these materials, and then using also this laser strategy with other tissues. But the concept is really that we have a filler, because now I think the concept moved more to that we really replace the cartilage as soon as possible, because the cells simply have to move in, and then they have their environment. They do not have to produce it on their own. And this is so important, because then we might reduce some other later on collateral damages on the peritraumatic cartilage around the defects, which are also overloaded when the scaffolds are too soft that are implanted. When the subchondral bone, we know that it changes when it's not loaded. And this could be also overcome when we have directly a load-bearing material. And also the collateral, so the contralateral tissues, they are also protected from inappropriate rough surfaces after implantation. So this is the concept, and we are now in translation to clinics. Let's say it like that.
And if I understand correctly, you're also looking at the cartilage around the defect to see whether maybe making the cartilage layer thicker and stronger from a biomechanical perspective, whether that also protects the cartilage around the defect. In what sense are you looking at that? Are you looking at whether there's cyst formation around, or how the cartilage quality is? How do you look at that?
At the moment, only histologically. And the thing is that so we did the small animal models, we did also large animal models, but it's very difficult to have an appropriate animal model when you have 6 scaffolds. And maybe we also do not need it and can translate it directly in clinics. We have to negotiate with the regulatory affairs. So this is at the moment a concept. And we are convinced that it's the better way, but we have no solid data to show it at the moment.
Yeah, and you're also looking at the subchondral bone you mentioned to see whether that has been affected or is affected after implanting a stronger scaffold. How do you look at that?
Same here. I mean that we couldn't prove that in the large joint so far. But what we also saw, and this is also an additional advantage, is that in some of our, we have a model, an osteochondral plaque model, which we use either in vitro or ectopically in the nude mice. And there we saw that when bone marrow is invading the defect, which is like microfracture, then this bone marrow is differentiating perfectly. I mean, we also saw this for chondrocytes and adipose-derived stromal cells, because the material, the cartilage, is chondrogenic. I mean, this has been shown already by other groups. But we had it also in these laser incisions, for example, that there was a premature differentiation. It was it was really impressive. And the good thing here is also that the material is very stiff, and that the bone marrow, once it's differentiated, it really forms also a nice cartilage tissue there, and so it can be combined, the material, also with microfracture. So you could implant it either with only a chondral defect, or a chondral defect with drilling through the subchondral bone with microfracture.
So in that sense, it would also make more sense that the bone marrow cells or the precursor cells are differentiating more into hyaline cartilage instead of fibrocartilage. Is that how I could also understand it, or?
Yeah, I mean, first of all, we implant hyaline cartilage. So most of it is already hyaline cartilage, even with the superficial layer. And there is no biomaterial which has a real superficial cartilage layer, a proper one. And then and in these incisions, there is this chondrogenic effect. We called it tip effect because it was really in the tips of these incisions that the differentiation was premature in comparison to the surrounding. This was the case for the chondrocytes, for the ASCs, and for the bone marrow cells.
Okay, that's very very interesting finding then, right?
Yeah, yeah. We're glad, and we hope that it works in human as well.
Yeah, because that's what you mentioned a couple minutes ago, that you're also working to the translation into the clinics. How is that currently going? How do you make that work, mostly from a practical point of view and a logistical point of view, and mainly also maybe regarding getting all the administrative work done? How is that process done? Are you involved in that, or some other people?
Yeah, I'm involved. Yeah, at the moment we're reaching out to companies and having negotiations with some companies because it's also patented, and when it comes to translation, it's and also clinical studies, then you need money, and therefore companies. This is the current the current situation that we are in this discussions, and because we are also working on the upscaling and on the fine tuning, on the standardization. Yeah.
Mm-hmm. And apparently your team is working towards that for the future to apply it in clinics. Are there any other insights that you can give to our listeners regarding maybe, let's imagine that we're in 2050 or 2040. You're maybe still working. Some of your colleagues are still working. What research projects are going on at that moment, and where will we have been at that moment in time regarding cartilage regeneration or your scaffold-based projects? Just take a look into the future.
I think what we need is in future a more holistic approach. At the moment, there are a lot of different approaches available, and it's like a vendor's cart, a vendor's tray. A lot of different methods, and everyone uses special methods, or is developing one scaffolds, one EVs, one stem cells, and I think we need to in future maybe combine them, because we maybe, especially for focal cartilage defect, we should not only treat the whole, because there is also the collateral damage on the other tissues via the trauma, and they also need to be addressed, and therefore we need adjunctive treatments maybe. I mean, there was already some research going on, but maybe I think it was not continued, and maybe some of the approaches which are currently under investigation then would be perfect to combine them. So I think we need to think broader, and we consider now osteoarthritis as a whole joint disease, and we also, after trauma, have to treat already there the whole joint maybe to avoid the development of OA.
Yeah, so you're really thinking of already with focal cartilage lesions or small cartilage lesions right after trauma. Think at the broad perspective, think holistically in that sense.
Yes, and I mean also that when we have focal cartilage defects and patients are having surgeries, some are already early OA. So then it's not enough to just fill the hole, because then maybe even if the defect is perfectly regenerated, the other tissues react and are the gene expression, everything is already changed. Yeah, and we know this also already from other studies, that then there are permanent changes going on after trauma.
And from your experience of the past years, if you think of 2040, 2050, and you think of these focal cartilage lesions like the pre-OA stage, and if you observe them from the holistic approach, what do you think are the top 5 most important factors to be considered in this holistic approach, besides the cartilage?
I mean, this is difficult.
Yeah.
I mean, because I can only answer this question from a current perspective, because
Yeah,
also
that's
in
perfect.
terms of what makes sense, because translation is also sometimes a pragmatic decision. Yeah, we can have the best stem cells if they are too expensive, or if the regulatory issues are too high to translate them. We better go for EVs. Yeah. So I think I'm personally convinced that once there is a severe damage, a structural damage, then it's not enough when we just inject something, because we need to fill up this damage. I'm now talking a little bit also on the more advanced OA situations, where we have really structural damage, which is then a later consequence of focal cartilage defects or whatever. So then these deeper defects must be filled up also with hematuria, but this cannot be the same scaffolds as for the focal cartilage defects. And then it's not enough to inject something. But when it's about inflammation or somehow influencing the cells and the tissues for the gene expression and so on, then also soluble factors are, I think, doing the job.
Yeah.
And soluble factors, this could be EV cells, and because when we inject ASCs or MSCs, then these are most probably soluble factors which are doing the temporary effect of temporary anti-inflammatory effect. And yeah, so I think it depends on the situation. As also now, I think we need clearer indications, we need patient stratification, we need more standardization, and then choose for the patient. I think this maybe in 2040 we know a little bit better our patients, and which therapy would be appropriate for which indication.
Yeah.
So this, I hope that in 2020, 2040, we have a clearer picture of that.
Okay, so then it's very interesting to hear that, because that's what you mainly hear from the guests on the podcast, is that when you ask them regarding the future, this is an answer that is frequently being stated, that we need to work towards patient stratification and a holistic approach regarding clinical practice and also scientific practice. So it's good to hear that also from your side. We're slowly going towards the end, so I'm gonna ask a few more questions on your career path, because when googling your name, I saw that you won the award of Researcher of the Month in December 2020. Could you tell us a little bit more about that award that you received?
Yeah, this was a award on a top publication, so in the top journal, which was on the auricular cartilage that I described before. This was the cartilage where we removed the elastic fibers to bring the cells in again. Yes, and this was it.
Okay.
The award was for this top publication.
For the top publication, and you were interviewed back then regarding that career path. You've had many career highs and awards, as we saw. Could you tell our listeners a little bit on where you get your inspiration from for your new projects? What's something that inspires you to think of new innovative projects?
I think the results themselves, and looking into the microscope and analyzing the the samples, this is very inspiring, because I mean, this is one step leads to the next, and in science, frequently afterwards you have more questions than you had at the beginning. You learned a lot, but there are more and more questions. And yes, and I think this is one reason for inspiration, or and then also discussing with colleagues, or simply thinking about a problem and how we could solve it, and because it's also a little bit sometimes with tissue regeneration, like in a workshop, to have to think practical, and when you like to do graft and have a little common sense, and then you come up with weird ideas, and then you try out and find something which works. And I think we have to think practically about translation, but also out of the box a little bit. So not doing the same but different. And but I think the research itself is most inspiring.
Yeah, no, I definitely agree. And you mentioned in the beginning as well that just reflecting back on that, because you now also gave us some inspiration on how we should get inspiration. But in the beginning, you mentioned that you also supervise PhD students and other students. For a young researcher, clinician like myself, what would be the tips or the advice that you would give to a young researcher just starting out?
I mean, I think it's exactly that. I mean that on one hand, it's important to be realistic that it can be translated. I mean, especially in our field where we are close to clinics, and then thinking different, thinking out of the box, and not maybe top down, not bottom up. It's not that we develop something and then we see if it fits somewhere, but where are the clinical problems and how could they be solved, and talk to people, talk to clinicians what they need, talk to researcher what's feasible, and discuss with colleagues. And what's, I think, very important also for research, it's not only important that we know our patients better, but it's also important that we know our methods better. I think we need more standardization. I think we need recommendations, what methods make sense, what readout makes sense. And I would also give the advice that you really critically think about the methods that you're using, because you can cause so much artificial results, and when you do not know your model very well. And this is also with the very, very easy standard models. You need to know them. You need to know everything very well, your media, and this is also where we are putting a lot of effort into to understand what we are using in the lab, because we know that the results between labs are sometimes very, very different. And this is also something. Be very critical with yourself.
Yeah. We'll take that into account, your advice. Thank you for that. Just slowly going towards the end, I would like to ask one more personal question, and that we sometimes also ask this to other guests. If you would like to have a cup of coffee or a cup of tea with one person in the world, he or she may be dead or alive, who would it be?
I think it's, I mean, there are there are a lot of very interesting people, but I think it would be Jane Goodall. So this is the lady which was living with the primates in the rainforest with the gorillas.
Yeah.
She did never study. I think at least not at the beginnings. She was trained as a secretary, and she wanted to go to Africa, and she went to Tanzania. She was in her 20s, and then she lived in the rainforest with the gorillas and studied them with methods which were totally uncommon at that time. So she was, etiology was completely different at that time, and she was a woman and was doing something very special, and so she must be a really brave and daring woman. And on the other hand, when she's talking, she's so calm and thoughtful and very charismatic. Yeah, I think, and she did this without any education. She was not at the university, and still she did so a good job in for science and for the animals. Yeah, and this is why she's really very interesting for me.
And have you had did you see a YouTube video or like a podcast on her, or how did you get to know?
I mean, I'm biologist, so I've heard from her several times, and there is also there is a documentation.
Yeah.
An old version and a newer version. So there is a
Okay, we can look her up, and then maybe provide a link to the people who are listening if they're interested. All right, thank you very much for providing your insights into the future of translating from the lab to the future patient with a cartilage lesion, or maybe just a whole joint osteoarthritis, and your insights on the research that you do in that sense. And thank you for getting to know you a bit better. Hopefully you enjoyed the podcast, and thanks for our listeners to be here again for the ONtheGO podcast.
Thank you for having me. It was really a pleasure.
This was ONtheGO, the podcast on orthoregeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening, and have a great day.